everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here from the Overrun. Danny, today we're going to talk about clearing C-spine, which is not a new thing, but not necessarily an old thing for some organizations that may not have dealt with it. This is coming from Katie Russell et al. From the Journal of Trauma and Acute Care Surgery. This is in April of this year. So I will say this is going to be linked down in the show notes. This article is incredibly long. The work that Russell and Kahan and Eldridge did on this is phenomenal. It is a very, very in-depth paper, and it is a paper that talks about radiology a lot. But the reason that we want to talk about it is they talk about cervical collars in here, and they talk about the actual clearing. They talk about screening procedures, imaging, plain film radiology, computed tomography,
yeah, it's a
all
very
this other
complete
stuff.
study.
It is. They cover damn near everything that you would need to know. So we want to encourage everyone to actually read this paper, which again will be linked down in the show notes. The important part that we want to talk about here is figure 2 in this paper. This is the Pediatric Cervical Spine Clearance Working Group algorithm. Now, this paper talks about clearing C-spine in pediatric patients specifically, where out in the field, we have adults that are being cleared all the time. It's fine. But what kind of guidance can we have on pediatric patients that have some kind of spinal injury? The big takeaway from this paper, and again, there's plenty of time to get into details of, when you're in the hospital, what GCS gets referred to CT, what gets referred to MRI. But the big point here for EMS is for pediatric patients, a Glasgow of 14 or 15, and essentially no point tenderness. You can clear their C-spine and be on their way. And again, this is the Journal of Trauma and Acute Care Surgery. This is the algorithm that they're working on for pediatric C-spine clearance. Big picture stuff, right? Glasgow 14 or 15, no neck pain, clear their C-spine. I think that's probably reasonable. And here in their summary, again, this is the important parts here. Cervical spine injury occurs in about 1% of pediatric patients after blunt trauma, which is another important factor to keep in mind, because if you're immobilizing these patients, are you immobilizing the 1%? Are you immobilizing the 99%? Which again is kind of the debate I think we had initially when we started clearing C-spine in the field. But what do we think so far, Dan?
Well, I think the idea of C-spine immobilization is pretty much falling out of favor, especially in the adult population.
Yeah.
I do know that it appears that there still seems to be a reticence about applying those guidelines to pediatric patients now. This has been a hot button thing. This is not again, you said, how we deal with spinal immobilization or motion restriction in the field has been changing over the last 10 years. This is going to also influence that. The question is for the field provider, for the person in the field, what does this change for you? Not a whole lot. However, this might be something to bring to your medical director, your clinical people, that, hey, if you have a kid who was involved in a motor vehicle collision, blunt force, whatever, and they're not having point tenderness, or they're not having any of those signs that are outlined in this paper, it may be reasonable in your service to not put a C-collar on these patients. There's been a lot of data that has come out about C-collars, that they're not as good at doing what we think they do, that they do cause cervical spine movement, cervical spine distraction. They cause airway issues. We're on the cusp of changing into something, and I know it drives people crazy because medicine changes very, very slowly. But I think this is reinforcing, again, universal spinal precautions don't really need to be done. We need to take a case-by-case basis, looking at mechanism, looking at the patient, and what is the patient telling you, whether through physical exam or just straight out saying it. Is motion restriction going to be indicated in this situation? A lot of things that we did in the past we're not doing anymore, and this may just be one of them.
Yeah, and again, this isn't new information, right? The spinal motion restriction was in the literature 10 years ago. And it does take time, which you're right, I think can be very, very frustrating. What this paper starts to talk about, and what it really gets into detail about, is it explains why we don't necessarily need to worry about using C-collars in pediatric populations. There's several reasons that go from physiology to anatomical differences, where children have more space, frankly, for their bodies to compress and move. There's plenty of anecdotes, like kids are bouncy where, you know, a child might experience something that an adult would be seriously injured by, right? How many anecdotes have you heard of our contemporaries, right? Where like, if I walk too fast, I'm going to break my ankle. And you'll see, you know, kids will run around and they'll fall and just get up and get right back to it. So, and all those are imperfect anecdotes, right? But in this setting, what we tend to worry about in EMS a lot is what could happen, right?
Yeah.
And it seems to me that we're with these patients for 20 or 25 minutes and we're worried about negatively affecting them for the rest of their lives. This documentation, this study, 1% of blunt trauma patients in the pediatric population have cervical spine problems. When we overcorrect for those kind of problems, when we put on, you know, we're going to put this kid on a backboard and a C-spine because I don't want to get sued, or one time I heard a story about a guy who moved and, you know,
Or the
you might be,
mechanism looked bad,
yeah,
whatever.
you know, there's the argument of we're over treating these patients, which I think is interesting,
We could
because
be.
I think the over treatment, right, the over triage can also lead to over treatment, excess medical care, excess bills, whatever. And then there's the other side where I worry that we're doing this because we're so worried about litigation that, you know, now we're getting back to we're causing
Well,
excess care because we're worried that someone might sue one day. And the point of this is what the evidence is suggesting now, right? There may have
yeah.
been a time where 30 years ago, you know what, we might get sued. So board and collar
we didn't
everybody.
we didn't have this data 30 years ago. We
Right.
didn't have all of the studies that are reinforcing to us that backboards are not as good for people as we think they are. Hard plastic cervical extrication collars are not doing what they're supposed to do. um a lot of them, I would say I'd love to see a study on how many of them are properly fit at a scene,
Yeah.
and then go to cervical spine clearance in the ED, and what the sequela from that is, because I
Mhm.
think it might find there's a significant percentage of people that have their injuries exacerbated by this. And I think the data is starting to back this up. Again, not something we're going to change our practice today, but we need to be prepared for it. It's definitely something I would show my clinical coordinators. I would show my medical director and say, hey, this is where
Hey,
this is
this
coming.
is what the data
And
is suggesting.
what's your
And it,
thoughts?
and it's more data that supports J.R. Pickett's claim that backboards cause cancer. So we gotta back that up as well.
White tiger.
Gotta check all this stuff out. But we want to know, obviously, what you guys think. Are we still boarding and collaring pediatric patients? We know that 1% of blunt traumas actually have these injuries. Let us know what you guys think. Click the bell down below to subscribe to everything that we're doing. Check out the podcast, the Overrun podcast on Apple Music and Spotify. And then check us out on EMS1 and everywhere else for the Overrun, the Monday Afternoon Journal Club. Ed Bowder, Dan Schwester. We will talk to you all next week.